It has been never so much ever, actually. And now suddenly there is so much to learn and so much to do. And as we were just chatting with other colleagues, it has become mind boggling. And so algorithms are changing so quickly, and newer tests are getting added. Just remember, only few years back, lung cancer was being treated. All kinds of lung cancer were same, and they metastatic lung cancer used to have just 1 year survival, be it adeno, be it squamous or whatever. And we used to give similar kind of chemotherapies. But now we are doing so much for lung cancer, and treating lung cancer has become so much interesting, and there's so much to do there. And I remember when I was training under Dr. Ashok Bair, and we just used to say it's just it's hardly a survival, and we should we just picking and choosing regimens like that. But now we follow so many algorithms: this test, that test, adeno, squamous, mutations, no mutations, PDL1, and percentages, tumor mutations. So many things are being done these days. Coming off next generation sequencing, MSI MMR. We used to read MSI MMR only for colorectal cancer. And now this is being used across the board for so many different things now. And so many new classes of drugs have come into being. And so we want to learn how to use all these tests, whatever newer tests have come, how to use these tests for covering the, and I have learned yours, and you can give your opening remarks and set the stage for today's meeting. Thank you, sir. Welcome.
Thank you, Sachin. That you've been very generous in your using your words, and thank you so much. And phenomenal. And I think the others might get sort of annoyed with us that this might become a sort of a mutual appreciation group. And before that happens, let me get across to my presentation. What I will do is I'm just sharing my screen, and can you guys see me, and can you guys hear me?
Yes. Go ahead, Ashok.
So what I thought that in the next 10 minutes, I would sound a little different, not for the sake of it, but for the completion of it. And I would take you through the entire spectrum of immunotherapies, though we would be discussing elegantly, extensively over the next 2 days about the immune checkpoint inhibitors, and because that is the real the topic for the current era. But I would take you through some of the less talked about concepts in immunotherapies as well, and very quickly show you some of the other concepts as well. As such, it is rightly said that immunotherapies have emerged as one of the strong pillars of oncology, apart from radiation, surgery, chemotherapy, targeted drugs. And who knows, this jigsaw puzzle would start getting extended to the left and the right, up and down. And then the more it happens, the better it is for the clinicians, and more so for the patients and their families. Patients are surviving longer with less toxicity and more convenience. Look at the spectrum. There are, other than immune checkpoint inhibitors, there are many cell-based therapies the clinicians talk less about. And I would show you that some of these are very robust, less talked about, less applied, because these are, pardon me for saying that, these are not off the shelf. These are customized. Every individual has to have his own customized therapy, because these are cell-based, and immune checkpoint inhibitors are off the shelf. These are more pharma-driven, and therefore can be subjected to mass production. You have a companion diagnostic, and then you have a drug, and the combo goes on. But don't forget the other therapies which revolve around the tumor-infiltrating lymphocytes, teaching these lymphocytes newer tricks, and causing these lymphocytes to work in a different manner to attack the tumor and cause the tumoral lysis in these patients. The basic is the activation of the killer T cell is the basis, at the heart of it. And once this switches on, this can go and attack the tumor in different variety of ways, and this can happen through the tumor infiltrating lymphocytes, NK cells, and others, and so on and so forth. Immunotherapy, we know, is not a new subject, and we have had over the last 30 years many attempts at manipulating these cells, bringing them out, expanding them, and then putting them back into the body, cross-infecting them with the viruses, producing those CAR T cells, and the story is on and on. And the latest out here is the many immunotherapy, the immune checkpoint inhibitor drugs getting approved for these indications. It tells, because tumors have these infiltrating lymphocytes, there is an opportunity to activate them and expand them ex vivo, reinfuse them, and use them to destroy the tumors. Again, the entire story revolves around the switching it on and getting the tumors to be attacked by these tumors and by these cells. One could expand them ex vivo, reinfuse them, and the whole technology could be harnessed through expansion by increasing the numbers. However, it's not only limited to increasing the numbers, these could be activated by equipping them with new T cell receptors, and both the numbers as well as the new receptors done ex vivo, these could be infused back and could be harnessed for tumor lysis. The big story of the last decade is the CAR T cell therapies, and both the tumor infiltrating lymphocytes and TCRs can be used to target the cancer cells when the antigens are bound by the MHC. Remember, these need MHC expression of these antigens. However, the CAR T cells can work even without the MHC, and these can only recognize a small spectrum of the antigens which are naturally expressed on these cells, like the CD19. And there is a range of potential antigens which can be harnessed for producing the CAR T cells. The process seems simplistic, that we harvest the peripheral PBMCs, the mononuclear cells. The patient receives the lymphocyte depleting chemotherapy, and these cells are taken out in the lab. They are transduction, and the retroviral transfection is done. The CAR T cells are produced and fused back. The process has undergone a lot of modification. Earlier, all this used to be done on different benches in the lab. Now there are integrated systems where you all put it as a cocktail, and after 5 to 7 days, you get the finished product of these CAR T cells. There are generations to that, as happens with most of the biological products, and it's the intracellular domain which are the co-stimulatory molecules which make the CAR T work better or more specific. The good old story of the first CAR T success from the University of Pennsylvania, this was a CLL, but the story is moved on, and then we know that the profound effect in lymphoblastic lymphomas who had undergone extensive treatment, even allogeneic transplants who had failed, they have had durable responses with CAR T cells. So that is the great success of the last decade. Two of these medications or these biological products which are available commercially, Yescarta and the Chimera with their complicated names, these are commercially available and approved for the B-cell malignancies. Natural killer cells are the latecomers. They are also being explored in conjunction with others. And the next two slides show you the number of opportunities, number of antigens or the surface molecules which are the subject of target for these CAR T cells. And imagine these sciences ever expanded. Last but not the least is the dendritic cell. This is a slide from Steinman's Nobel Prize presentation. Again, the PBMCs are harvested. They are cultured with growth factors. Part of the tumor repertoire is introduced into this. These become immature dendritic cells, and they mature over a period of time, ex vivo, and millions of these dendritic cells are reinfused into the body, who have been taught how the tumor antigens they look like. And then these are the ones which are harvested and done. This was our publication, and this was a group of patients who had been very, very extensively treated, and there were some meaningful responses. And based on this, the government of India gave the approval. And this is one of the micro photographs from one of our the dendritic cell preparation. Millions of these cells are put back into the body, published in Cytotherapy 2014. Big story, immune checkpoint inhibitors. Sachin just made a mention about the number of these therapies which are available, and I just did a count on that. In 5,000 plus therapies based on purely on biomarkers, and that is the number of trials which is on. This is the slide you would be seeing over the next 2 days many, many times, and the immune checkpoint inhibitors being approved in every and any condition. Talk about that in different settings, different lines of treatment. I can't take you through all of this. I come to the end of my presentation with a slide showing what is FDA approved. The 3 of these therapies are FDA approved: CAR T cells, dendritic cell, as well as the immune checkpoint inhibitors. A lot of work still needs to be done on the TILs and the NK cells and the engineered TILs, which are the T cell receptor manipulated cells. I thank you for your patient listening, and back to Sachin, over to you. And I thank you for this opportunity to be part of the proceedings, and right at the beginning for the great opportunity you gave me out here, and for all your kind words, and all the best for the next 2 days. And I'm sure under your dynamic leadership, this would
be senior. So we are not able to absorb so much because of. So she will be speaking on giving us more information on NGS and MSI, MMR, tumor mutation burden. So many things are new, and how to apply them, how to interpret them. A lot of things need to be put in proper perspective. So I welcome Madam for her lecture. Please go ahead, ma'am. Please unmute. Please unmute. Not yet. We have to unmute still.
Can you hear now?
Yes.
Yeah. Can you share my slides? I seem to be having a problem. Yeah. Yeah. Is it okay now? Am I seen and audible?
Yes, ma'am, you can go ahead.
Yeah. So first of all, you must understand that I am a clinician. So I am going to be talking more from the application point of view of all these technologies, rather than going into extensive details of the process itself. You know that the next generation sequencing has become an invaluable tool to put genomic sequencing into clinical practice. And many of the challenges which were faced initially have been overcome by the incorporation of clinically relevant genomic sequencing into the NGS panels, so that there has become a wide use of this NGS right from diagnosis to therapy, to actually come into the era of precision medicine in oncology. It is important to note that the current NCCN guidelines incorporates these NGS tools in almost 67% of their guidelines. Now, how has this sequencing evolved? You know that it began in 1977 when Sanger received the Nobel Prize for the Sanger sequencing, And from then on, over the past 3 decades, it has moved on to the current next generation sequencing, which is a high throughput DNA sequencing and has very important advantages of a small sample size requirement, low reagent costs, and a quick turnaround time as compared to sequential testing that we were used to doing in many solid tumors. Next slide. So, next slide. So, we can say that the next generation sequencing has stimulated the next generation of cancer diagnostic. So, how is it defined today? It's a type of DNA sequencing technology that uses parallel sequencing of multiple small fragments of the DNA in a single reaction. These are parallel actual sequencing of many small fragments of DNA of the tumor in a single reaction to determine the sequence. Next slide. So, what is the basic process? As I said, I won't go into the details. Being a clinician, I would want all the clinicians to be aware of the basic processes involved in this. So, we begin with the sample collection and DNA extraction. This can be done from paraffin tissue from the blood as called the ctDNA or cfDNA, or by the DNA obtained by reverse transcription of RNA, because you know that apart from NGS where DNA is used, you can also have NGS where RNA is used. But there too, you have to reverse transcription of the RNA to DNA is required. Then you come to actually the template generation. So this DNA which has been extracted from a tumor is fragmented, and this fragmentation depends on which platform being used, its size really depends on that. And then there is a ligation to the adapter, and then this ligated adapter as well as which is called as the primer along with the DNA fragments of the tumor are then immobilized either on a solid surface or on beads. And this you can call as the tumor template or the tumor sample DNA. And this is the one that you're going to sequence. And the sequencing is actually done by fluorescence attached nucleotides, which then get attached to this tumor sample and it actually reveals the sequence. So that is how the interrogation of the sequence of the tumor is done. Now, the nucleotides, as I said, could be actually using fluorescent dyes. It could also use what are called as pyrophosphate or H ions. So these are different techniques and they differ according to the NGS platforms that one uses. Finally, you come to the last part and the most difficult of all, and that is the data analysis. So you can just visualize that you're in parallel sequencing multiple gene fragments, DNA fragments. So it generates an enormous amount of data, and this then electronically and computationally aligned against the normal tissue, and that is how you get the data that you see on the NGS platform. So next slide. And this is just to put it into a proper perspective that you have the flesh, the tissue, and then the DNA extraction, then the NGS process, which I have just actually described, and then going on to the actual report after the data is completed. Next slide. So the basic workflow, as you can see from sample collection, then I've just given you a little bit of detail of how the DNA is fragmented and then how the template is prepared by adapter ligation and then how it is sequenced by attaching the nucleotides and then the data analysis. Next slide. So there are different types of sequencing. That is the whole genome sequencing, then the whole exome sequencing, and the targeted panel sequencing. Now, the whole genome and whole exome sequencing are actually very time-consuming and expensive procedures. So most of the time, what is now used is the target panel sequences, which may be 20 to 100 gene panels, And as you know, some of the ones that we are using may go up to 400 gene panels to 500 gene panels. As you would know that our DNA has about 20,000 genes, and of which 500 genes are actually involved in tumorigenesis or the carcinogenic process. Next slide. So these are all the sequencing platforms which we use in practice. I think most of you are quite familiar with platforms such as the Foundation one. Then you have the CARIS, and then you have the recent one is the Garden one, especially using GI malignancies, and then you have several others, and then of course you do have those which are also used in the blood or the plasma. Next slide. Now, the applications, of course, as Dr. Ashwin has brought to your notice, that we have several gene panels for NGS in India. The applications, of course, as Dr. there are other panels being used by various companies and with a number of genes involved, but much lesser than the 400 to 500 genes which some of these others which I mentioned actually use. Now, what are the applications of the next generation sequencing in cancer? The first application that comes to mind to us all clinicians is the gene alterations, that is the molecular targets for targeted therapy. Now, as you are aware that the next generation sequencing can detect mutations, the single nucleotide variants, copy number changes, that is amplifications, then structural abnormalities like insertions, deletions, translocations, fusions. But you must know that depending on the select panels that we use, sometimes large deletions and insertions may be missed. And then, of course, the common used malignancies, apart from some of the hematologic malignancies, are non-small cell lung cancer, melanoma, ovarian and breast cancer. So these are some of the cancers. Next slide. So now let us come to some of the recent data, especially from the Asian counterparts of using this NGS, especially in lung cancer, which is the most common cancer where we use it. So we are used to a sequential genes target recognition, but now with the use of NGS, you can look at all these at once. So if you look at this Chinese study, they have selected about 60 patients, and using the NGS panel, they found these mutations in 68% of the patients, and you can see they range from EGFR, KRAS, BRAF, or B2, ALK. So these were the mutations that they found in their limited sample. Next slide. And this is the recent data from the TMC, which is the next generation sequencing in lung cancer and Indian initial experience of 154 cases. They looked at the mutations in 72% of the patients, the most common being the T53, 6%, EGFR in 32%, KRAS in 18%, ORB2 in 3.2%, and BRAF in 1.94%. So you can see that by using these panels, instead of doing sequential testing, you can get the results at one shot, and this is in a much shorter time than you would expect by doing sequential testing. Next slide. Now, this is the MSK impact study, and they have their own platform. And you can see that they have done the NGS in more than 10,000 patients of metastatic disease of various histologies. 37% had at least single mutations which were clinically relevant. 1,000 patients also chose to go for the germline mutations. So 17.5% were linked to genetic predisposition as opposed to 5.10% that we get in the population when we study it by other methods. And of course, then you have the anti-RK fusion detected. Next slide. So now look at the second NGS application, and which we are again very familiar with, is detection of mutations conferring resistance to treatment. The standing example, one of the most important being the T790M mutation in patients who are on TKIs, especially like gefitinib and orlotinib. Then, of course, you have the RET mutation, the MET mutations in non-small cell lung cancer. Then you have the KRAS, NRAS, and BRAF, which confer resistance to the anti-EGFR therapies. So these are some of the important applications of the NGS as far as detection of mutations conferring resistance to therapy. Next slide. You come to the third important one, and that is tumor mutational burden. Now, I will not dwell much on this because it is still in the realm of investigation rather than clinical application. What it actually detects is hypermutated tumor, which has a high number of somatic mutations, which actually determine the tumor mutational burden. Mutations cause development of new antigens and susceptibility to immune checkpoint inhibitors. Next slide. Of course, I won't go further into the details because, as I said, it still remains an investigational tool. A high tumor TMB is associated with clinical efficacy of immunotherapy. There is no consensus today on the methodologies and the cutoffs. And when the whole exome sequencing was used, there was data on pembrolizumab where there was a longer PFS. The checkmate also 0 to 6 showed longer PFS, but you can see that the cutoffs are varying. Next slide. Now, applications of NGS also in microsatellite instability, and this I will go into details when I come to MSI. Next slide. Then, of course, there is application of NGS because you can detect several genes which are responsible for the DNA repair pathway, and the mutations in this could render this pathway deficient. So you have the NGS detecting other mutations apart from the BRCA1 and 2, and thus indicating a sensitivity to the PARP inhibitors. Next slide. And then important one is biomarker driven clinical trials. So it is detected, that is the, you detect biomarker with the NGS, and these are the patients who are then selected for the clinical trials. And the most important examples are like the French Shiva trial, which of course did not meet its endpoint, and so it did not match up. So when they used it and compared it to standard therapy, the patients selected on the basis of the biomarkers did not do better. But you must remember that these were three rather outdated markers which had very limited molecular targeted therapies, and that may to some extent explain the failure of this trial. Then you have the NCI match and the ASCO TAPUR study. Next slide. So you get all these trials grouped into umbrella and basket trials. So basket trials are actually driven by a single mutation in various cancer types, whereas the umbrella trial is driven by histology with different mutation. Next slide. Applications in, so this is the NIGHT study which looked at the liquid biopsy being equivalent or even better than the tissue based. Next slide. So the advantages of NGS, as you see, is that it has a lower cost, but of course that is for the future. At present, it is expensive, but some of the panels which are available in India are cost effective. You need a lesser amount of tissue and less time. Next slide. The challenges and disadvantages are the cost, the standardization, the clinician's interpretation of results, which is most important. You get the report, it is very important how you interpret this and put it into practice. And of course, the patient education, because when you talk of such sophisticated techniques, the patient's aspirations are extremely high, and one should explain, especially in the later lines metastatic setting, that it has limited value, and after spending that much, they may not get a targeted drug. And one must also explain the implications if in the somatic mutations you do find some mutations which are relevant for the hereditary panel. Next slide. And this is one of the knowledge base tool which is available to clinicians to actually interpret these results. Next slide. Now coming to the last part is the mismatch repair system. You are very much aware of that. That where there is damage to the sequence of nucleotides, then the DNA, this is recognized by the mismatch repair system genes like the MSH3, MSH6, and MSH2. And once it is recognized, then the repair of this occurs by a combination of the four well-known genes, which I'll come to next slide. And then you have the microsatellite instability resulting from the dysfunctional DNA repair as a result of a mutation in one of these genes or hypermethylation. And then it is diagnostic for hereditary syndromes, predictive for response to immunotherapy and 5FU, and prognostic in GI cancers. Next slide. So these are the consensus recommendation on MSI standard definitions. I won't go into details. I'm sorry, I'm not able to make out whether I've run out of time. So repetitive DNA sequences in coding and non-coding regions. So because of the mismatch repair, you have a collection of these nucleotides leading to microsatellite instability or MSI high tumors. Next slide. So then you have the DNA mismatch repair, which I have already alluded to, and four genes which are important, which we are all aware of. Next slide. And then you have this definition of microsatellite instability, which I have already alluded to, and also that thousands of these mutations actually accumulate as a result and lead to the MSI tumors, MSI tumors. Next slide.
Please, wind up.
Yeah, this is the last slide. Next slide. Next slide. So this is the determination which we are aware of immunohistochemistry and molecular biology. Next slide. And this is the interpretation in the colorectal cancer of the Lynch syndrome. If the BRAF is mutated and if it is the BRAF wild type, then you know that there is it may be sporadic. Next slide. And then the predictive marker as far as immunotherapy and 5FU is concerned, and the last slide. So the conclusions are that NGS has become an integral part of personalized therapy. MSI is an important predictive and diagnostic tool, and TMB is predictive of response to immunotherapy, but it is still investigational. I'm sorry for running over time, but I'm not able to see the timing on my screen, and that is the reason. Yeah, next slide. That's it. Thank you.
Yeah. Thank you, ma'am. Thank you. That was very explained very well, and it has also set the stage for our next panel discussion also, which is again related to the topic you have just discussed. And for this panel discussion, I want to invite Dr. Govind Babu. Dr. Govind Babu sir is a very senior medical oncologist, and sir also doesn't need any introduction, and he's presently working at SCG hospitals, and formerly he has been professor and head division of medical oncology at the prestigious Kidwai Memorial Institute of Oncology in Bengaluru. Sir, the stage is all yours. You can invite your panelists and start the discussion, please.
Thank you, Sachin. So, the list I have is Dr. Amish Vora, Dr. Jatin Sari, Dr. Anupa, Dr. Arun Kumar, Dr. Amit Verma, and Dr. Aparna. I don't know how many of them are there.
All of them are there, sir.
Oh, yeah. Okay. Can you see my screen?
No, still no.
Okay. second. One second. I would like to ask.
We all say yes, sir.
Okay, thank you. So let's go ahead. I'll just give a brief about why we need to do it, because as Ricky already laid the nice foundation, we're always looking at cancer genes and mutations. There are about 140 driver genes, 60% of them are tumor suppressor genes, 40% are oncogenes, and more than 1,000 driver gene mutations are known today. And most tumors have anywhere from 2 to 10 driver mutations. So this is a very familiar picture for all of you, that we know DNA is the genomic storehouse, but we have taken a long time from knowing this to using this to the advantage for our patients. So let me start with a small trivia. Each cell has DNA. Can anybody tell what is the length of this DNA strand? Okay. It's about 2 meters. Okay? And we have about 100 trillion cells in the body. And if you put the DNA end to end, it is more than 100 times the distance of Earth to Sun. That is, Earth to Sun is 98 million miles. So that is how much of information stored in our whole body. And just to put the whole thing in perspective, it's about 25,000 strands of DNA, if put together, is equal to a single strand of human hair. So this is just to put everything in perspective so that we understand. This is just to tell you that the cancer mortality has definitely decreased over time. This is data from 1930, and this is published this January, showing you that there is a definite fall in both men and women dying due to cancers. And I believe it is because of this, because we are looking at personalized cancer. Therapy, we're looking at markers, and that is what this whole panel discussion is going to be about. So this is just to show you some of the major cancers and how it has changed over time. For example, non-small cell lung cancer, there's a nice terminology I found. It was a non-segmented lung cancer. But today, in 2016, we have so many segments that are there. So I would just like to say that from an unsegmented view of tumors, we've gone to segmented, and today we are talking of multi-segmented tumors. So I think that is what is being the molecular markers doing for our tumors and ultimately helping patient care. So let's start with breast cancer. So this is just to show you the timelines, how we have progressed. And let's start with a case. This is a 46-year-old lady who was presented with a right breast mass. So she's premenopausal, no relevant past history. She undergoes a lumpectomy with axillary dissection, and the histopathology is IDS, T2N0M0, grade 3, ER plus, 70%, PR negative, ER negative. And she has 0 lymph nodes positive. Her tumor is high grade and 1 centimeter in diameter. How will you manage her treatment? Maybe I'll start with Amish here.
Yes,
What
sir.
would you do next to manage her?
So, less than 50-year-old
Yes.
lady, that is a fundamental differentiation. Second thing, she's ER 70% but grade 3.
Yes.
So this is a little dichotomy in this thing. Assuming the grade is high grade,
Yes.
grade 3.
Yeah.
Lymph node negative, T2N0.
Yes.
I will offer genomic assay, but I would be happy if she decides for chemotherapy, because in both Taylor-X and Mindec 8.7 years follow-up data shows that people benefit when in less than 50 years age.
So I will come to that next. So this is NCI guidelines in 2001. They said adjuvant chemotherapy for any tumor that is more than 1. And at that time we knew that there is benefit, yes. To all, no. Toxicity to all, yes. So that was where we stood. But now we have progressed. So with all these, and as you are talking about, we are looking at gene genetic profiling of tumor. So essentially, we are looking at who can be spared adjuvant chemotherapy because we do believe, in spite of being medical oncologists, that chemotherapy is toxic. Right, Amish?
Yes, sir.
Okay. Okay. So now over DX. Now you can take over and tell me a little more about all these.
No, thank you, sir. I think if I understand correctly, the idea of asking the question is which patients genomic assay and where we can spare.
Right.
That's the whole idea.
Absolutely.
So we have two large studies, Taylor X and MindX. One is on Oncotype DX and one is on MAMA. Both have shown that in an intermediate category, you can avoid chemotherapy if the patient fall into low risk. One is on 70 gene, one is on 21 gene. But both had caveat less than 50 years, patients benefited with chemotherapy, addition of chemotherapy. So anybody more than 50 years, postmenopausal, early breast cancer with low risk genomic assays, clinically low risk, I think these are the patients we should avoid chemotherapy as of 2020 today, sir.
Okay. Jatin, what is your take on this?
Well, I agree with Dr. Amish. Yes, less than 50 years, the patients do benefit with addition of chemotherapy, but for more than 50 years postmenopausal, one can offer these tests if they afford. And in low risk subtype, we can safely avoid chemotherapy. There is hardly any benefit in that.
Okay. Dr. Aparna, what is your take on this? Because you are slightly on the other side of the fence as far as we are concerned.
No, I completely agree. Based on the trials, it does make sense that if the patient can afford, this would be a good option, these genomic assays.
Dr. Arun, you are from MedGenome, so what is your take on these?
Yeah,
Because I agree from a scientist as well.
Thank you. I too concur with the findings because the clinical trials are quite compelling to use this, and they are good. The results are good. The prediction rates are also pretty good. So yeah, as of now, this can be used upon.
Okay, Dr. Anupa, what is your experience with this?
We can't hear you, Dr. Anupa.
Yeah, she's there. Okay, as she's coming on, what about Amit?
Okay, I agree with Dr. Amish what he said.
Okay.
And she qualifies for not to go for genomic access as of now because we are not very sure how much benefit we give avoiding chemotherapy in this case.
So you don't even want to do
yeah, so I would because it's quite clear-cut case for us to take chemotherapy.
Okay. So this is just one slide which I took to show in the UK how this use of Oncotype DX has shifted the initial thing of looking at chemotherapy and hormonal therapy and how it has changed the number of patients from getting chemotherapy into hormonal therapy. So this is just from one country, but there is enough data from several other countries as well showing you the use of this Oncotype DX. I think there are several other platforms that are there. Dr. Jatin, would you like to talk about the other platforms similar to Oncotype DX or differing from Oncotype DX, which you are aware of and there in the market?
There is a platform of ProSigna, which gives its recommendation based on relative risk of recurrence score. We have a platform in India which is IHC based, that is Scan which we have used in some patients, and that is quite reasonably okay. But it is not part of guidelines yet. So these two I remember, and the rest are Oncotype DX, MammaPrint. One is I think breast cancer index. Index.
So I found this interesting article from JAMA. Actually compared the various platforms that are there, and they put out position papers. What they concluded was the clinical pathological late recurrence, genomic assays, all these have shown clinical validation for late recurrences, value above and beyond clinical parameters. But the key facts in decision making is looking at the toxicities for extended endocrine therapy, the absolute reduction with extended endocrine therapy. So these are the things that most of them would answer. So back to our patient now. She got ovarian function suppression plus an AI. Would all of you agree with this?
This after chemotherapy, sir?
No.
Patient did not go for chemotherapy.
Yes, did not go for chemotherapy.
The panelists agreed for chemo.
That's right. But this patient was counseled. She said no. She had heard about some things that you can avoid chemotherapy, that you can do this. So she took this.
So if she has taken this, it can be justified because there's a lot of criticism between 45 to 50 years
that's right.
whether the effect of chemotherapy was on causing menopause versus the actual toxicity effect of chemo.
That's right.
We can justify this step.
In fact, right now there's a study ongoing comparing chemo versus hormone therapy. That probably will answer the question. Okay, so this patient, 4.5 years later, came back with symptoms. CT scan showed numerous lytic lesions throughout the skeletal system, obviously metastasis. Bone scan shows the increased activity in all these regions mentioned. And she underwent the right iliac crest FNAC that showed adenocarcinoma consistent with the metastasis, which means that there is a marrow involvement. So at this point of time, these are the options that you have. What would you do for her?
Should I answer?
Yeah, go ahead, Jatin.
Yeah. So this lady was ER positive.
Correct. But
Right.
negative?
To negative ER positive, and she has been she's showing secondary resistance to
Correct.
So
0.5 years later.
yeah, and if she has been given an AI along with ovarian suppression, I think we can go ahead with this trend with CDK4/6 inhibitor first choice, and along with goserelin.
So in fact, that's what she got, but some of this is getting highlighted. She got fulvestrant plus CDK4/6 inhibitor, and which took for almost 14 months. But at that point of time, she came back with increasing back pain, and the PET scan at this point of time showed metastasis in liver, lungs, and bones. And even by age and the therapy that she had become postmenopausal by this time. So what would you do next? Amit?
Yeah, I would like to have the MGS right now on the patient to see what are the reasons for resistance and if I can use
any specific thing you want to look for at this
PIK3CA is my potential target.
Okay, so this is the recommendation from the guidelines talking about how you do PIK3 mutation. So this patient.
Sir, I have a small suggestion or comment.
Yeah.
If the PIK3CA based on this Solar One trial has been approved with fulvestrant.
Correct.
And in this patient, my question is, should we use PIK3CA? Now it is available PCR based method also. Should we use it before we use CDK4/6 so that we keep our fulvestrant option open?
In fact, this was discussed at one of the meetings of PIK3CA inhibitors. And what happened was the CDK4/6 inhibitors came in first. But in some places, these two came at the same time. So some of them have been using alpelisib even before CDK4/6 inhibitors. But they found this, the toxicity of alpelisib to be a little high. And they found that in limited number of patients, whether you use alpelisib first or CDK4/6 inhibitors first, and then you use the other, the responses are very similar. So since the experience with PI3CA inhibitors is still limited, so most people do believe that you go ahead and use CDK4/6 inhibitors and then use the PI3CA inhibitors. And the PI3K mutations are very stable. So even if you have done it on the initial archival tissue, even now it will not have changed. So that is
And you can reuse aromatase inhibitors with PIK3CA mute.
No, sir, I'll tell you why my point was that in a bone-only limited disease, now she has liver
now
plus
she
lung, but in a bone-only liver limited, this fulvestrant plus alpelisib have shown to be beneficial because fulvestrant also works in bone only.
Correct.
My point was, going in future, we'll get these dilemmas every day.
Of course.
Should we keep fulvestrant for alpelisib, PIK3CA, and use another hormone before we use? That was the question, sir.
In fact, there is retrospective data for fulvestrant use. They have said using it earlier lines, the responses are better.
True.
So that is another thing, confounding factor that will come.
Right, sir.
So we still don't know all the answers.
We don't know.
Yeah. So this is just about detecting it in tissue or plasma, and again, the lesson that we have learned from T790M mutation, doing it on liquid biopsy, and holds good for the PI3CK mutation as well. So you can do it as a liquid biopsy, and if that is negative, then you need to try and get the tissue. If it is positive, you can use your therapy based on the liquid biopsy itself. So this patient was started on alpelisib, and we continued the fulvestrant. Because like Amish said, that is what is the good thing. So I think she is ongoing treatment for this, so we will stop. So this is the proposed algorithm in those patients who have no visceral crisis. So this is going to actually change. So even in visceral crisis, we will soon get evidence to say that you don't really have to use chemotherapy upfront. Okay. Now back to the same patient. This is slightly hypothetical. Everything same. She is HER2 plus now. So Jatin, what would you do?
Yeah, so she requires the chemotherapy along with the anti-HER2 antibody. Even though she is node negative, but she is grade 3, so T2. So I would give the full one.
So this question is: do you consider HER2 as a predictive or prognostic? Dr. Anupa, are you audible now to us?
So can you hear me now?
Yeah, yes, go ahead.
Finally.
Sorry, I'm on my phone now.
No,
So I think in today's era, I mean, it is definitely predictive because we will be selecting our treatment based on, because she's HER2 positive.
Yeah.
And I would say I'm not sure that I would completely agree with prognostic, because in today's era, such a patient who has a small, the size of the tumor, even if she's HER2 positive, she has a 90 plus survival.
Correct. So this is just to show you that when trastuzumab came in, or just before that, overexpression of HER2 was associated with poor prognosis. So it is a prognostic, and this is to show you that it is predictive also. So this is the NEGM paper of Dennis in 1999 to show the advantage of using trastuzumab. So what about adjuvant trastuzumab? Who would like to take this? Yeah, Anubha, go ahead since you're audible now.
So for this patient, I would use paclitaxel plus adjuvant trastuzumab.
Okay.
The week
So we are not going to discuss the chemotherapy part because we are talking about molecular markers. So so trastuzumab. So this is the data. Of course, this is an old slide now, 2006. But even at that point of time, we had data these 4 last trials. We should have put over 13,000 patients to show you that using trastuzumab in the adjuvant setting was in fact beneficial. This is one interesting slide I thought I'll just show again. This is a note at 2008. So this is showing you that how many patients were actually benefited in absolute numbers. Almost 27,000 patients from 2005 to 2015 benefited from preventing recurrences when trastuzumab was used. Any comment on this, Amish?
Awesome.
In fact, this was interesting data, so I just thought I'd put this up.
Very interesting, sir.
Yeah, really. So, okay, breast cancer genomic analysis. So we are talking about trastuzumab use.
Can I just very quick comment? So there was ASCO 2020, there was very interesting article which was a paper which was published, was Monarch. So this particular patient, if relapses, you can use CDK4/6 with HER2, and they found that patients do very well. So in fact, delaying more further and further, since we are talking of molecular targets, I thought that that is something very interesting paper.
Yeah. I think all these hormonal therapies and targeted therapies have actually, brought about this concept of delaying chemotherapy for our patients. You preserve their general condition and you prolong them to such an extent that you can reserve your chemotherapy for later lines, preserving the quality of life and general condition.
Nowadays,
So this is
low HER2. This concept of low HER2 positivity also comes. So there are antibody drug conjugates who check into HER2. That is also interesting.
Yeah. So, are there any gene signatures for response prediction to anti-HER2? Let's ask Dr. Arun Kumar, since he's from the lab. Dr. Arun? Gene signatures?
Yes.
Yeah, go ahead.
Yes. Say for HER2 resistance, there are a few mechanisms such as overexpression of HER2. One thing, the other is mutations in ERBB4 or ERBB3 genes, and they are one of the mechanisms by which resistance for HER2 therapy is coming.
So this is one paper, actually this is an abstract only, which looked at 32 genes in 372 breast cancer patients, and they showed a 5-year relapse-free survival with a p-value of 0.001. This was a paper presented by Dr. Edith Perez in San Antonio. But I have not seen the full paper of this, so I really don't know how it has been gone forward. Okay, we would look at PI3CK mutation in HER2 positive disease.
Yes.
Yeah. And why would you do that?
It confers the resistance to HER2.
Yeah. So this is a paper that I got talking about mutations which blunt the response to anti-HER2 therapy. And these are all the studies which have shown that this is in fact true. Of course, this is all retrospective data, but it was prospectively collected for PI3CK mutations.
In the absence of any data benefiting addition of PIK3CA inhibitor like alpelisib, these are all only prognostic markers.
Correct.
PIK3CA positive will not respond well to chemo, also will not respond well to anti-HER2 also.
Correct.
But we do not have any combination of anti-HER2 with alpelisib right now.
Absolutely.
So I think it would more of a research product rather than must-have clinic.
Correct. That's why I put it towards the end of our discussion. So this is just to stipulate your thoughts. So I think with that we'll complete breast cancer. Let me go on to non-small cell lung cancer.
So we have about 3 minutes.
Oh my God!
So we some significant point want to
Oh my God! That only one tumor. Like I told you in the beginning, I don't know how many we can do. Okay. This is lung. This is a 63-year-old lady who I saw in 2008. She had EGFR 19, exon 19 deletion. She was in gefitinib and she responded well. But as usual, 14 months they do show resistance. What do you do next? I think this is all everybody knows now. But if you had seen her in 2020, what would you do? Amish?
The gefitinib alone is now a pass of the past. So either if the patient...
No, we are talking about molecular markers. Now forget the treatment.
The molecular markers, if the patient can afford, if the tissue is available, NGS is the way to go for.
Okay. So this is the new taxonomy for metastatic non-small cell lung cancer. We're looking at everything that is possible put up on this slide. And as you heard from the previous talk, NGS is the way to go about to do this. Tissue versus liquid biopsy, we discussed this in breast. In lung cancer, again, we have data from looking at EGFR. This is for objective response and PFS showing you that either you test in the DNA or in tumor tissue, your responses are very similar. So also for T790 mutation. So that is an established role that can either do liquid biopsy or tumor tissue. And this is the targeted therapies that we have today. Therefore, NGS is the way to go about to do everything. Since we don't have time, I don't think I can do the next 3 tumors. So I think we'll stop with that, and I would ask each one of my panelists to give some final comments. Amish, you can start.
Thank you, sir. Since I have spoken the most, I would like other panelists to speak about
Okay. Arun Kumar?
Yeah, I would like to just emphasize upon one practical difficulty we as a laboratory face.
Yes.
The quality of the FFPE block, number
Yes.
one, and the amount of tissue available.
Yes.
So if NGS is done upfront, the amount of tissue available is also more, and the age of the block is also less.
Correct.
So they do certain things that, especially in the Indian scenario, we find that the quality of the formalin used is pretty bad.
Yeah,
And
and not buffer formalin. Yes.
Yeah.
So we've been taking classes with the pathologist now, so they are also sensitizing everybody, including the intervention radiologist and the pathology lab, as to how they need to really process the tissue. And I think it's getting better. And as medical oncologists, we are very well tuned to getting the extended panel upfront. So I think that's okay with us.
That's
Dr. Anupam?
that I would like to make.
So I think this is something in progress. Like in non-small cell lung cancer, we have understood that NGS is the way to go. But I wouldn't completely agree for the other tumors such as breast, etc. And I think as the future, as in the future, we will probably know more how to understand and use these NGS in other malignancies and understand the mutations, and then
Since you're running a molecular tumor board, what are your thoughts?
I would say that whenever you encounter something unusual in your response to the treatment, or you have early failures, I think NGS should come handy. And sometimes you get quite good answers, and which will be beneficial for the patient, especially early run actually.
Yeah, I agree.
That's
So
my take on it.
ultimately, I think you need to be a good clinician and not just depend on what is there. If you find that your patient is not responding the way you expect them to respond, intervene immediately and look for what else you can do best. Yeah, that's a very good point. Dr. Aparna, your final comments?
So I agree with the panelists. As and when where we can use NGS, it is an absolutely brilliant platform. It doesn't always have to be one of those extensive large panels. It can be something even small, which is organ specific. Another comment that I also agree with Dr. Arun. We do tend to face this issue in the lab where we don't get good quality of, unfortunately, blocks, and then we have a very awkward conversation of calling a physician and saying tumor consumption, or poor DNA quality. So I do agree with that. But the one point that I want to highlight is that in a lot of cases, we are starting to see a trend where unfortunately people are getting diagnosed under the age of 50. And like we saw in this case, it's the breast cancer. And I would urge everyone, please do send them in for hereditary testing, because while it may not be of much help to the patient diagnosed, you could possibly prevent or help manage the rest of the family.
Yes, we have time for ovarian cancer, otherwise we're going to discuss that. Okay, these are the last 3 slides. I must show them because I made these slides recently. So this is how our OPDs used to be in 1990 when I started. Medical oncology, surgical oncology, radiation oncology. But it's progressing to breast oncology, thoracic oncology. But what I see in the future will be EGFR oncology, HER2 oncology, BRAF oncology, BCR-ABL oncology. So that's how I see it. So in conclusion, cancer therapies from empirically determined therapies would go extinct like the dinosaur way, and molecular-based therapies are there to stay to bring about a nice rainbow to our patients. So with that, I will stop. Sachin, thank you. Sorry, I couldn't cover the other 3 tumors.
That's fine, sir. That was wonderful.
Thank you.
Now we move on to our next session, which is for the lung cancer. And I would love to invite our chairpersons for this session. Dr. Colonel Ranganao, sir. You're most welcome. And Dr. Meenu Walia and Dr. Shekhar Patil. I don't see their names. Have they joined, Meera?
Yeah, Sachin, I'm here.
The stage is all yours, sir. Please.
Mutation negative, driver mutation positive, lung cancers, and then after that, immunotherapy in stage 3 lung cancer, followed by personalized therapy discussion. And another panel discussion, Ullas Batra has been looking for answers to his question in every panel for last, I think, 6 months. The same panel again and again, same panelist also sometime. And I hope he's found the answers and he will tell us the answers.
Thank you, sir. As already mentioned by you, we have a very interesting session today. And I think without delay, we can invite our next speaker, Dr. Anupam, who is a senior medical oncologist at Patel Hospital, Jalandhar, to deliver the first talk. Over to you, Dr. Anupam.
Thank you very much, ma'am, and thank you to our chairpersons and all the faculty and delegates who've joined in. I will be speaking on the optimal management of mutation-negative advanced lung cancer. I hope I'm audible. Hello? So,
yes, you are.
While all of us like to, next slide please. While all of us love to treat, we all send NGS on most of our patients with the lung cancer, especially the adenocarcinoma and the adenosquamous. Can you move to the next slide, please? No, the previous one. I apologize for this. I'm not able to control my slides because I'm calling in from the mobile. The computer was not working. So anyway, we all understand and we send NGS on most of our lung cancer patients. And while a lot of them would have targetable druggable mutations, there'll be a large number of patients who will not have any mutations and whom we will have to decide what systemic therapy and what approach we will be taking. In fact, it appears from the data from TMH that the patients without druggable mutations is actually a little bit more in the subcontinent. So for those patients, next slide please. We have an algorithmic approach where we look at the histological subtype, we look at we do the molecular profiling. If they have no mutations, we look at the PDL1, and now more and more we are also looking at the tumor mutational burden. We have learned to subdivide these patients who are mutation negative into 3 big subgroups that are PDL1 more than 50%, PDL1 between 1 to 49%, and those who are PDL1 negative less than 1%. Next slide, please. We have the basic armamentarium at our disposal currently for these patients is chemotherapy, age-old chemotherapy, targeted therapy that was introduced in the early 2000s, and of course, the latest kid on the block, which is immunotherapy. And through the next slides, I will show you how the treatment has evolved, and we will spend most of the discussion basically on immunotherapy. Next slide, please. So, of course, when we are treating patients with stage 4 lung cancer, we of course have to apply the general principles. We need to palliate their symptoms. If they have bone and brain metastases, we offer them palliative radiation, orthopedic stabilization. We offer them denosumab, bisphosphonates, and pain control. These days, however, something that I find a little difficult in advanced lung cancer is how to counsel these patients, because while at the end of the day it is incurable for majority of the patients, there will be a small subset of patients who could have long-term control. So how do we counsel the patient, keeping them hopeful but also preparing them for the reality of the disease? Despite all the advances that have taken place, the fact remains that for most of our patients it is incurable. Next slide, please. I will just briefly touch on chemotherapy because all of us are quite familiar with the chemotherapy regimens used in advanced non-small lung cancer. We know that platinum doublet is better than supportive care alone. We know that patients who have a good performance status, platinum is better. There appears to be better response rate, and there were some trials that showed perhaps an increased overall survival. But for most of us, we substitute carboplatin, where we find that cisplatin cannot be tolerated, and as lung cancer is mostly seen in the elderly, I feel that for most of us, probably carboplatin is the agent of choice when we combine with in the platinum doublet. Single agent chemotherapy for the elderly is definitely an option. There was the eldest trial that showed that vinorelbine alone was better than by supportive care. Sometimes we may consider non-platinum doublets. And of course, we all understand that based on the histology, whether they are non-squamous or squamous, we will choose the appropriate partner for the platinum doublet. Especially in non-squamous, we will consider pemetrexed, and in squamous, gemcitabine or the vaccines. Next slide, please. So, in 2000, we looked at this trial, which was the role of bevacizumab in non-small cell lung cancer. patients were given paclitaxel. There were two arms, was paclitaxel and carboplatin alone, or the combination along with bevacizumab. There was a slight improvement in median overall survival, 12.3 months in the bevacizumab plus chemo arm versus 10.3 in the chemo alone arm. This was statistically significant. They found that there were a larger number of patients who were alive at 1 year, 51% in the bev plus chemo arm versus 44% in the chemo alone. And the difference persisted at 2 years. The response rate was significantly higher in the bev plus chemo arm versus chemo alone, however, at the cost of increased toxicity. A couple of years later, next slide please. The toxicity profile, of course, was increased neutropenia in the bev plus chemo arm, an increased rate of hypertension, proteinuria, and the one that is probably the most horrifying for patients is the increased risk of bleeding events. And with that, it came about that patients who were squamous, who had untreated brain metastases, and those who were at a risk for increased bleeding should not be chosen for this particular regimen. Next slide, please. In 2013, they looked at the Point Break trial, looked at bevacizumab with pemetrexed and carboplatin versus bevacizumab with paclitaxel carboplatin, and they found that while there was no difference in overall survival, there was a slight increased number of patients who were alive at 1 year with the PEM plus PEM carbo-bev arm as compared to pacli carbo-bev arm. Next slide, please. The one big difference that did stand out was that the pemetrexed plus platinum plus bev had a better toxicity profile as compared to the paclitaxel carbo-bev arm, especially especially the neuropathy, which we all know can be very debilitating for patients. There was a combined analysis of both the ECOG 4599 and Point Break, and they found that this combination did show survival benefit for those less than 75, but none for the older age group. And I think now most of us are probably not using this combination in favor of the newer therapies that have come about. Next slide, please. Just a brief point about another targeted agent, ramucirumab. This has been approved in the second-line setting in combination with docetaxel, as it provides a slight improvement in OS and a slight improvement in performance of progression-free survival. Next slide, please. But the real thing I think that has changed treatment for patients with non-small cell lung cancer who do not have any druggable mutations is the advent of immunotherapy, as we're all familiar with the NCCN guidelines. And based on the PD-L1 levels, they have divided treatment of these patients. If they are more than PD-L1 more than 50%, PD-L1 1 to 49%, and PD-L1 less than 1%. Next slide, please. Next slide, please. So I will start with the use of immunotherapy as a single agent in advanced non-small cell lung cancer with this trial, which is the Keynote 024. This looked at patients who had a PD-L1 more than 50%, and they were randomized to pembrolizumab alone versus a chemotherapy doublet for 4 to 6 cycles. As you can see here, there was a significant difference in the progression-free survival. The response rates were higher, 44% in the pembro arm versus 27.8% in the chemo alone arm. The grade 3 and higher adverse events were lower in the pembro group. And there was a 2019 survival update which showed that for the patients with PD-L1 more than 50%, overall survival with pembro alone was 30 months as compared to 14.2 months with chemotherapy alone. It's almost doubling your survival. And at 3 years, more than 40% of patients were still alive in the pembro group as compared to 25% with the chemo alone. I have to admit that I think that in this trial, the chemo alone arm also did quite well, because most of us know that with chemo alone, most of the patients do not live beyond, the 1 year survival is about 15%, but perhaps because the crossover allowed, patients got on to receive pembro or immunotherapy in the second line setting. Next slide, please. As we talked before, the side effects were much lower with the pembrolizumab compared to the chemotherapy group. Next slide, please. But what we did realize that it is not all roses with immunotherapy, because there are immune-mediated adverse events seen in 30% of the patients. The grade 3 or higher immune-mediated events were about 10% in this group. And the most common was hypothyroidism, followed by hypothyroidism and pneumonitis, infusion reactions, etc. Next slide, please. I'm sorry, can we go back to the previous slide? Oh, yeah, this slide. The other trial that bolstered the use of single agent pembrolizumab in the patients with a PD-L1 score more than 50% is the KEYNOTE-042, which looked at the use of pembrolizumab versus chemotherapy alone in patients who had a PD-L1 more than 1%. And as we can see here, for the entire cohort, which includes patients from 1 to 50% and higher, there was a significant difference in overall survival. In the pembro alone group, it was 16.7 months versus 12.1 months with the chemotherapy. Next slide, please. Of course, the benefit was higher in those who had a PD-L1 more than 50%, and in that subgroup, the overall survival with pembro alone was 20 months versus 12.2 months. So the study seemed to think that most of the survival benefit was derived from the patients who had higher levels of PD-L1. The one point, however, that is interesting in this trial is that even for the patients who had a PD-L1 between 1 to 49%, pembro was not inferior to chemotherapy, as the median overall survival was more or less the same. And so perhaps for some patients who have a lower PD-L1 but are not willing to take chemotherapy, pembrolizumab alone for the subgroup could still be an option. Next slide, please. What about the combination of immunotherapy with chemotherapy? We have the KEYNOTE-189, published in 2018. This looked at stage 4 non-squamous non-small cell lung cancer without an EGFR or ALK mutation. And they randomized the patients in 2:1, pembrolizumab plus pemetrexed and carboplatin or cisplatin versus placebo and chemotherapy. The pembrolizumab was continued up to 31 cycles after the chemotherapy was discontinued. Next slide, please. In this, the PD-L1 assay used was 22C3. We will see that with nivolumab, the different assays used. And they had 1/3 of the patients with PD-L1 less than 1%, about 1/3 between 1 to 49, and 1/3 of the patients had a PD-L1 more than 50%. Next slide, please. As we can see here, for the entire cohort, the overall survival was significantly in favor of the pembro plus chemotherapy combination. It was, at the time the trial was published, it was not reached versus 11.3, and in the 2020 survival update, it was 22 versus 10.7 months. So there was a doubling of the overall survival with the use of pembrolizumab in the patients with a PD-L1 more than 1%. The progression-free survival was also almost double. And the chemotherapy and the toxicity of pembro plus chemotherapy was as expected. The one thing that the authors wanted to point out, that there was an increased number of patients in the pembro plus chemo arm who discontinued the chemotherapy. In this subgroup analysis, the further point that I wanted to highlight was that the overall survival was improved regardless of the PD-L1. So while, of course, it was higher for those who had more than 50%, even for those who had less than a PD-L1 less than 1% or a PD-L1 between 1 and 49%, the addition of pembrolizumab to the chemotherapy was superior to chemotherapy alone. Next slide, please. KEYNOTE-407 was looked at pembrolizumab plus chemotherapy for the squamous non-small cell lung cancer, and in this trial too, we find that there was this significant improvement in overall survival for the combination of pembro plus chemotherapy. So both for non-squamous and squamous non-small cell lung cancer, the combination of pembrolizumab plus chemotherapy is a valid option. The response rates are also higher. In this trial too, the response rate was almost 60% with the combo compared to 37% with chemotherapy alone. Next slide, please. The grade 3 or higher adverse events in this trial seem to be similar in both groups, about 68%. Again, they have the higher discontinuation rate, however, with the pembro plus chemotherapy arm, almost double as compared to chemotherapy alone. Next slide, please. So we've looked at pembrolizumab alone. We've looked at the combination of pembrolizumab plus chemotherapy. What about the combination of a targeted therapy to immunotherapy and chemotherapy? What is the additional benefit? This was answered by IMpower 150 trial, which had 3 arms. Atezolizumab with chemotherapy versus atezolizumab with chemotherapy and bevacizumab, and the last arm, which was the bevacizumab plus carboplatin and paclitaxel alone arm. And the trials, the trial results that have been published have been looking at the bev carbopacli versus bev carbopacli plus atezolizumab. Next slide, please. In this trial, the addition of immunotherapy to the bev carbopaclitaxel versus bev carbopaclitaxel alone showed there was a significant improvement in progression-free survival and overall survival. The rate of patients who had progressed at 12 months was almost double. The number of patients who were alive at 12 months was almost double in the immuno bev carbopacli arm as compared to the bev carbopacli arm alone. And the risk of death was lower and the response rates were higher. Next slide, please. However, I think one of the problems with this in our setting will, of course, be cost. And given that we have such good results with immunotherapy plus chemo alone, I would question the use of the addition of bevacizumab in the current scenario, except for one particular group, because patients who have EGFR or ALK and who have progressed on the targeted therapy can go on to receive immunotherapy in this combination, because this subgroup was included in this IMpower 150 trial. A couple of my last slides are looking at the use of combination immunotherapy, and we know that there is now data for nivo plus ipilimumab given by this Checkmate 227 trial, which is a very complicated trial divided into part A, 1A, 1B, and 2. Here we have just the part 1, in which patients were divided into 2 groups. In the first group, they about 400 patients received a combination of nivolumab plus ipilimumab. The second group received chemotherapy alone, and the third group received nivolumab alone. In the 1B part of this trial, the patients were subdivided, with those who had PD-L1 less than 1% were given either nivo plus ipi or chemotherapy alone, and the last group received nivolumab plus chemotherapy. There were co-primary endpoints for nivolumab plus ipilimumab versus chemotherapy, which is what was published. They looked at the PFS in these populations based on TMB, and also the overall survival in the entire cohort. Next slide, please. So the first results that were published were the combination of nivo plus ipi in patients with a high tumor mutational burden. We know that patients who have a TMB more than 10 megabase appear to have improved results with this combination. The progression-free survival at 1 year was 42% in the combination arm versus 13% for chemotherapy alone, with a higher response rate and not an increased rate of grade 3 or grade 4 toxicity. So this held true regardless of the PD-L1 expression, whether it was more than 1% or less than 1%, regardless of the histology. And it appeared that even patients who had low PD-L1 but a high TMB benefited from this combination. Next slide, please. And this held through also in their progression-free survival, where you can see that at 1 year, 43% in the combination arm was alive as compared to 13% alone in the chemotherapy arm. Next slide, please. Next slide, please. So this was the subsequent follow-up results on this trial, which looked at the combination of nivolumab plus ipilimumab versus chemotherapy alone for all patients. And in this, they found that there was a difference in overall survival in those patients who had a PD-L1 more than 1%, about 15 months in chemotherapy alone versus 17 months, a 2-month survival advantage. The interesting point in this is that the median duration of response was 23 months as compared to 6.2 months with chemotherapy alone. Next slide, please. And even for patients who had a PD-L1 less than 1%, the difference in overall survival remained, and in fact it was increased with chemotherapy arm doing 12 months alone versus the combination reaching up to 7.2 months, a difference of about 5 months. Next slide, please. And this is the entire cohort, which all showed benefit, survival benefit. Next slide, please. There was some secondary endpoints also that were evaluated in this trial. For patients with a PD-L1 less than 1%, the Nivo plus chemo combination had an improved performance, progression-free survival. The hazard ratio for progression or death was also significantly in favor of the combination of Nivo plus chemotherapy, but the overall survival was not that different. In the PD-L1 more than 1%, they did manage to show that the combination of Nivo plus EP versus Nivo alone had an improvement in the duration of response. The majority of the improvement seen in those with a PD-L1, more than 50%, where the duration of response was almost 3 years. Next slide, please. Next slide, please. This is the last trial, which was recently discussed in ASCO 2020, where they looked at the combination of nivolumab with ipilimumab with 2 cycles of chemotherapy versus 4 cycles of chemotherapy alone. The primary endpoint was overall survival, and there were secondary endpoints of progression-free survival, response rates, and efficacy based on PD-L1. Next slide. They showed that as regards the primary endpoint, there was the combination of Nivo plus EP cycles of chemotherapy was superior as compared to 4 cycles of chemotherapy alone, with a difference of about benefit. So perhaps in the future, the PD-L1 may not matter for those patients who may not matter if you are going to be receiving a combination of Nivo plus EP. Next slide, please. Because I focus mainly on the first-line therapy, I just have one slide that has shown that for patients who do not have a mutation and who have received chemotherapy alone, do we have several options when they progress. In the past, we had only docetaxel or gemcitabine, but now we know that immunotherapy has stepped into this particular scenario as well. And we have 3 agents that are currently approved in the second-line setting, which is nivolumab, atezolizumab, and pembrolizumab. And here I have the results of Nivo versus docetaxel, which was one of the first trials that was published in 2014, and that showed that there was about a 3-month survival advantage for immunotherapy docetaxel with nivolumab versus docetaxel alone. Next slide, please. So, my conclusion actually is that in today's era, can we go to the next slide? Next slide. Is that today the inclusion of immunotherapy for patients without a druggable mutation has improved the survival. There were average survival prior to immunotherapy was anywhere between 10 to 12 months. With the arrival of targeted therapy, we improved it 2-3 months more. But now there are some patients, albeit low in number, who are able to survive for almost 3 years. The important point that we have to, the factors that we have to consider, however, when we are selecting therapy is, of course, tumor histology, the PD-L1 score, but eligibility for immunotherapy. While we all like to think that the toxicities are decreased as compared to chemotherapy, there still remain significant toxicities with immunotherapy that can prove to be fatal. I will share one patient of ours who was given pembrolizumab and had a very good response. However, she developed pneumonitis and we had to give her steroids. After the use of steroids, she ended up developing a fungal pneumonia and actually died from the fungal pneumonia, which was quite heartbreaking given that she responded for her metastatic lung cancer. So the eligibility for immunotherapy, the appropriateness of that patient for chemoimmunotherapy, and if we are using bevacizumab, then the eligibility for bevacizumab has to be looked at. I think one of the biomarkers that will emerge with more use in the future is the tumor mutational burden, because we have seen how TMB trumps PD-L1. For a high TMB can trump PD-L1, and perhaps
you have to wind up now.
Yeah, this is my last slide. So yeah. I think perhaps In the future, we will not be using chemotherapy at all and maybe just looking at a combination of PL1 and CTLA4. Thank you so much.
Very nice talk. And Dr. Shyam Agarwal, please, over to you.
Thank you. Cover the EGFR mutant non-small cell lung cancer. Okay. Now the lung cancer slide. Cover the EGFR mutant non-small cell lung cancer.